Hello, this is Dr. Bhaumik and welcome to my lecture series again. Today and from now onwards, it will be a little bit different. Over the period of 43 years in my academic medical career, I have seen many interesting patients which are indeed rare, and many of them I have presented in Pediatric Endocrine Society meeting in different regions, and many also have been published as a case report in peer-reviewed journal. I personally like this format where I can present a case and then we do the discussion. So from now onwards, I will present very interesting cases, and I believe this will be very interesting to you all. This case has been designed and presented in such a way so it will be very interesting to the pediatric endocrinologist, pediatric endocrine fellows, as well as pediatrician, pediatric resident, and medical student, including pediatric nurse practitioner. So today I'm going to present a very interesting case, but before I do that, by the time I was preparing for that, when I was at South Alabama, and our new children's hospital was pre-innovated, and so I was proud of that, and we used to present this picture in various presentations. So this was our children's hospital, and this is the brand new clinic that the open pediatric endocrine section was right here. With that show and tell, let me discuss what is my goal and objectives of this presentation. Obviously, I am going to present a case of non-autoimmune thyroiditis, and you have heard my lecture about autoimmune thyroiditis like Hashimoto's thyroiditis, Graves disease, etc. But this is a non-autoimmune thyroiditis presentation. I will discuss the presentation, signs, symptoms, pathogenesis, diagnosis, and the differential diagnosis of this condition, and imaging techniques and studies that we usually use to make the diagnosis of this case, and we'll discuss the management challenge and brief literature review as well. This was a 10 years old girl who was admitted to the pediatric floor with neck pain, difficulty in swallowing, and she had prior history of sore throat. For about a week to 10 days, she is also persistently running fever 100 to 102 degree Fahrenheit. And she is holding her neck in a little bit extended position, and it hurts in a lateral movement and downwards movement. And appetite is poor and can't sleep very well at night. So going back to the past medical history, what we found that she had this similar episode few times before, but none of them have been this severe. And she has gone to her pediatrician, who many times told her that this is probably her sore throat, bacterial sore throat, and they prescribed antibiotics, and she did get better few times. Because of the suspicion of this recurrent sore throat in earlier age, a tonsil and adenoidectomy was done at the age of 6 years. And she has otherwise been healthy, growth and development has been age appropriate, and her immunizations are up to date. Her physical examination, she actually looked sick. Her temperature at the time of exam was 101.5 degree Fahrenheit. Her heart rate was varying between 100 to 120 per minute. There is a definite restriction of the neck movement, and the pain is easily elicited with a different type of movement of the neck, especially if it is bent forward and in little lateral position as well. She has difficulty in swallowing. The other physical findings was enlargement of the anterior cervical lymph node on the both sides, more so on the left side. And the throat examination actually did not show any significant erythema or exudate. And her tonsil was removed as I mentioned before. So the following lab evaluation was done, and that shows her WBC count was high, 14.8, with bandemia, say about 80%, band about 6%, and mono 6%, lymphocyte 8%. Her C-reactive protein was 30 milligram, which is elevated. Her cell rate was 62 millimeter per hour, which is also elevated. We did a mono test, TB skin test, throat culture, those are all negative. She has a normal chemistry profile. Her thyroid profile shows a completely normal free T4 TSH, and she has negative thyroid peroxidase, anti-thyroglobulin antibodies, as well as thyroid stimulating immunoglobulin was also negative. A CT scan was done, which shows about 2.5 centimeter solid cystic mass in the left thyroid, possibly an abscess. Thyroid sonogram was done, which is pretty much same, so the evidence, suggestion of abscess of same size also. You can see left side a sonogram shows. Then, so the ultrasound guided aspiration was performed. About 2 ml of brownish yellowish purulent fluid was obtained, which was sent for culture. And the culture actually grew 2 bacteria, Strep aureus and Strep viridans. She was started on IV clindamycin and third generation cephalosporin, rosapine, and local surgical incision and drainage of the abscess was performed a third day because she continued to be febrile. So after that, her fever remitted, and IV antibiotics was continued for 5 more days, and she was discharged home on oral antibiotics. So her diagnosis was acute suppurative thyroiditis, bacterial thyroiditis. Now I want to discuss a little bit about literature review and acute suppurative thyroiditis per se. This is infection of thyroid gland, and this is extremely rare. About 0.1 to 0.7%, and most of the infection has occurred before the age of 40. There has been no clear-cut male-female uh, difference, and the most cases are caused by all the commensal or the bacteria that lives in oropharynx. It could be aerobic, anaerobic bacteria, but most commonly is the Streptococcus viridans, Staph aureus, and so on. Condition is very rare, as I said, and it is much rarer than subacute thyroiditis or autoimmune thyroiditis. And sometimes it may mimic like them, and other thyroiditis, excepting subacute thyroiditis, are not associated with fever. And the pain is also not a common features in other form of thyroiditis, excepting subacute thyroiditis. Pathogenesis of acute suppurative thyroiditis. This slide is very important, and this will tell you why the bacterial infection of thyroid gland is so uncommon. I like to divide it in three parts: anatomic, physiology, and biochemical. Anatomically, this thyroid gland is isolated from the neighboring structure and very well capsulated. Very well capsulated. So the entry of bacteria to the gland is very difficult because of that physiological barrier. Now, anatomical barrier. The physiological barrier, we know the thyroid gland is highly vascular and also has a rich lymphatic drainage system. Any gland who is so vascular, or for that matter, any organ that's so vascular, get less infection because very easily that autoantibodies and all can be brought to this area of infection very quickly. So this is highly vascular with a rich lymphatic system. Now, biochemically, let's look at that. What is thyroid gland contains? Is iodine. Iodine is very hostile to the growth of any bacteria. But also, if you remember, during the formation or organification of iodide to iodine, what enzyme is necessary? Thyroid peroxidase, TPO. What is peroxidase? Is also another antibacterial substance. And so, because of this anatomical protection and the physiology as well as the biochemical of the gland, this is so protected against the infection from outside. So, when this infection occurs, so what we really need to think? The first of all, in children, we have to think about that pyriform sinus and thyroglossal duct fistula. And I have a diagrammatic representation of pyriform sinus. It actually originates from the tip of the left pyriform sinus is actually more common. And it is the remnant of third and fourth pharyngeal pouches and extend from the pharynx to the thyroid capsule, and it acts as a channel through which the bacteria from oropharynx can directly descend to the thyroid lobe. And the Although there is piriform sinus as well as thyroglossal duct remnant can present on both sides, and most of the inflammation or abscess has been seen on the left side. If this is not taken care of, then the recurrent acute thyroiditis is going to occur. But besides that, if the patient is immunocompromised and also receiving radiation in the thyroid gland area, they are more susceptible to develop bacterial infection. This is the diagrammatic representation. Here is the piriform sinus, and piriformatic like pear-shaped or a dumbbell-shaped. Pear-shaped, and it can come, bacteria can come through this sinus and settle right here. In our case, this is a little picture shows that little piriform sinus remnant. As I mentioned, the most common is the Staph aureus, Staph pyogenes, pneumonia, Staph radians. Sometimes it could be polymicrobial. That means more than one organ may be involved. And the prevalence of methicillin-resistant Staph aureus is increasing, so one need to be worried about that and be careful when you choose the antibiotic to cover that organism. And about 30% of the cases, it could be more than 2 to 5 organisms may present and may be responsible for abscess formation. Anaerobic also can occur. This could be usually oropharyngeal flora, as I mentioned before. Fungal infection that has been described in the literature, very rare and usually immunocompromised subject, and that usually is aspergillosis, coccidioidomycosis, cryptococcus, and pneumocystis carni. And most cases, as far as the presentation is concerned, the most cases of acute suppurative thyroiditis present with sudden onset, pain and firm tender swelling, usually on the left lower side of the neck, and it moves with the swallowing, and which is the characteristic finding for any node or any lesion in thyroid gland, or within the thyroid gland it will move with the swallowing. Could be associated with fever, chill, rigor, and sometimes there could be the hoarseness of the voice beside difficulty in swallowing. And the symptoms develop over the period of days and sometimes weeks. And this neck pain, unilateral neck pain can radiate to the mandible. And that's one of the things that I did not mention, that our patient was also complaining of left mandibular pain. Flexion of the neck, when you try to flex it, and extension usually make the pain worse. Laboratory finding, as we found in our patient, there will be leukocytosis, elevated Z rate, elevated CRP, thyroid function is normal. More than 90% of the cases is normal. And if the patient has fungal thyroiditis, the patient could be hypothyroid. And few literature that I found, very few, and if the patient has microbacterial infection, the patient likely to be hyperthyroid. So that 10% that I mentioned, those who have fungal infection likely to be hypothyroid, mycobacterial infection, patient is likely to be hyperthyroid, but they are transient. Once you take care of the problem, the patient becomes euthyroid. The imaging studies is important and will make the diagnosis for you. The sonogram of the neck is most important. It often shows the unilobular swelling or already abscess formation. CT MRI is not generally needed, but CT may be a good idea also, unless the sonogram is equivocal. Thyroid scan uptake is not necessary. If it is done, it will show the decreased uptake in the area of abscess, will almost look like a cold nodule, but when you got all other information, it's really necessary. So as far as the management is concerned, is the antibiotic is the sheet anchor of the management, and it should be broad spectrum antibiotics which will cover all the all the bacteria that I have discussed. If there is no clinical improvement within 48 hours, the abscess, it should be reassessed and surgical drainage is necessary, especially if the sonogram is suggesting of abscess formation. And evaluation of the risk factor, especially the piriform sinus of risk factor, is very important. Otherwise, the chances of recurrence is high. Now let's talk about the follow-up of this patient. This patient actually, removal of tonsil and adenoid was not necessary most likely, and it actually removed the first line of defense and make the patient more vulnerable to bacterial invasion. We have 4 years follow-up on this patient. There was no recurrence, and we did remove, we ablated that piriform sinus at the time of her discharge, and we have follow-up thyroid antibodies, thyroid function test, which has remained normal. And as I said, there was no recurrence. So acute suppurative thyroiditis should be high index of suspicion is necessary, is about 0.1 to 7%. Must be differentiated from subacute thyroiditis, for which the treatment and management is different. And our next case we will discuss about that. Sonogram is cheaper, easily available, and actually prove superior imaging study. Prompt antibiotic therapy and incision of drain of the abscess is very important to cure this condition quickly. Anatomical defects such as piriform sinus fistula must be sought and should be taken care of. And TFT Thyroid function test, as I said, will remain normal and vast majority of the cases, excepting that the few that we have discussed. I like to finish with the picture and the name of the three great pioneers in thyroid disease: Fristi Kuruvan, Hikaru Hashimoto's, and Robert Graves. Thank you very much. The next presentation will be another case presentation, but that will not be acute suppurative thyroiditis. Thank you very much, and I'll see you in my next case presentation and lecture series. Thank you.